As an interventional pulmonologist, I have a few different roles. I'd say that the earliest point we meet patients is when they present with a lung nodule. And that just means there's a spot seen on an X-ray or a CAT scan that we don't know what it is. Initially, we'll do the workup, which can be CAT scans, PET scans, or things like biopsies. Most of the time we do bronchoscopic biopsies, meaning we go through the natural orifices in the airways, navigate out to a nodule, perform biopsies, and look at the lymph nodes for staging. If a patient has cancer, we then complete the staging and refer them to a thoracic surgeon, radiation oncologist, or medical oncologist as the need arises. We often come back into the picture later on, either if another biopsy is needed, for instance, if they're started on a therapy which stops working and the oncologist wants to assess for a new mutation. Sometimes we'll come back into the picture if the patient develops breathlessness, and that can be because of treatment-related side effects such as pneumonitis or inflammation of the lungs. Also, if a patient develops fluid around the lungs, like pleural effusions, we would perform drainage of that or place catheters so the patient could drain at home and stay out of the hospital. We also perform palliative procedures, meaning we remove tumor from the airways if it's causing shortness of breath, and we can support the airways using stents. And so we're involved in a supportive role, first with diagnosis and staging, and then with palliation of symptoms to keep patients out of the hospital and on treatment.